ECG tells us a lot more than just ischemia. And if I take it outside of the setting of chest pain, I've got other places in emergency care where it becomes a very valuable tool. And one of those is in the setting of overdose and toxicology, particularly polypharmacy overdose. So I want to take some time to go over some of the manifestations of cardiotoxicity that we can see on an EKG, okay? We have to really review the cardiac conduction cycle before we can make any sense out of this, okay? And the reason is because when I interfere, when I create a cardiotoxic effect with a drug, it's typically because I've blocked some sort of receptor or interfered with cellular signaling, okay? And the consequence of arrhythmias or cardiac abnormalities is going to be a manifestation of that alteration. And I can really narrow it down to sodium channel effect, potassium channel effect, and calcium channel effect, okay? Really, honestly, that's about what it's going to boil down to, okay? And then there's some of these will have like AV nodal effect and what have you. But in general, it's going to be calcium, potassium, and sodium, okay? So you have to understand the role of those electrolytes and the channels associated with those electrolytes to make sense out of what's going on here, okay? How does this manifest? It manifests in changes in intervals. So a normal EKG has very predictable intervals that we see on a normal PQRST cycle, right? If I have a cardiotoxic effect, it manifests through changes in those intervals. So we'll review normal intervals. Let's talk about tricyclics, which are really sodium channel blocking agents. We call them tricyclics because we gave a bunch of depressed people tricyclics in the 80s and they decided it's a wonderful thing to overdose on, right? So they popularized the sodium channel cardiotoxicity, right? But there's a lot more than just tricyclics that can cause sodium channel blocking effect, okay? So we'll talk about sodium channel blockers, the tricyclics. We'll talk about long QT drugs. We'll talk briefly about digoxin, and then beta blockers and calcium channel blockers, okay? So here's the cardiac conduction, or cardiac action potential, and I've got it right next to a nerve cell on this diagram, right? The nerve cell is in green. The cardiac myocyte is in red. These are the two systems where we are absolutely dependent upon excellent cellular signaling, okay? If my muscles are not totally up to par on muscle signaling, my skeletal muscles, then I might be a little slow to get out of bed that morning, right? If my gut isn't quite operating the way it should, I might get a little bit of constipation or diarrhea, right? But if my nerve cells are altered, then I get seizures, okay? And if my cardiac myocytes are altered, then I get arrhythmias, okay? Neither one of those is great in terms of survivability, right? Eventually, long enough of either one and you're going to have devastating effects. So that's why we look at these two systems, and any time that you get a manifestation of both of those symptoms together or systems together, you ought to be thinking sodium, potassium, calcium, okay? Right? If I have a guy who is seizing or I get called to a seizure and I notice that they have a wide QRS and runs a VTAC, I'm thinking sodium channel blockers, right? I'm thinking sodium abnormality, low sodium, right? Or sodium channel blockade. That's the classic manifestation of severe tricyclic is seizures and VTAC, okay? And it's because I'm affecting the cardiac action potential, or action potentials in general, right? So when I set this resting membrane potential, this is where I'm at when I'm ready to be fired, when I'm ready to be signaled, right? How do I establish this gradient across my cellular membrane? How do I set up a gradient from the intracellular to the extracellular space? And I do that with a sodium-potassium pump. I shuttle in or I pump in two potassiums, and I pump out 3 sodiums with every cycle of the sodium-potassium pump. So I have a net gradient of 3 positive charges out and 2 positive charges in, which gives me a net negative charge. Does that make sense? So I have a net gradient here that develops because I pumped 3 positive charges out and I only let 2 in. If I do this 1 billion times on a cell, then I can generate a negative charge on the inside of the cell and a positive charge on the outside of the cell. And that becomes my resting membrane potential, right? And by potential, it means that I have a gradient set up in everything in the body. Like, biology works because of gradients, okay? I can send water from this point to this point because there's a gradient to do it. I can generate a charge, or I can open a channel, or I can make cells function because I set up a gradient and I let things drive or fall down a gradient, okay? I use energy to create a gradient, and my work is done by trying to restore that gradient to equal. Does that make sense? So this is the motor of the body. The motor of biology is setting up gradients, okay? I hold on to water in my blood vessels because I have a greater osmotic gradient, right? I have more solute stuck inside my vessels, primarily in the form of albumin. So I hold on to more water inside my blood vessels as opposed to outside my blood vessels, right? What happens, what disease process results in reduced albumin production? Think of people who have too much fluid in places where it shouldn't be. What organ produces albumin? Your liver, right? If I screw my liver and I end up with cirrhosis, I have low albumin, right? You've seen these bad liver disease patients, the cirrhotics. What happens with them? They third space their fluid, right? They leak fluid out of the vessels and they can't recoup it back in. So they develop third spacing, particularly ascites, because it becomes a high gradient, high pressure system. So they push water out and can't hold on to it because they don't have a healthy gradient established to hold on to water. So that's how the body works, by establishing gradients. This is an electrical gradient that we use to drive cellular signaling, okay? So I have my resting membrane potential, negative 90, right? When I trigger depolarization, it's an all or none phenomenon, right? I hit a benchmark. When I hit that voltage criteria, I get a universal effect throughout the cell. It's not this slow gradient of opening up sodium channels. When I hit that mark, it all goes off at once, okay? Every channel opens. And the result of that is a massive, massive influx of sodium that was outside of the cell in high concentrations into the cell, okay? And so what does that do to my intracellular charge? It takes it close to 0 because I've equalized that gradient. I've taken a polarized resting state and I've now depolarized it. It's what we refer to when we say cardiac depolarization, right? So I drive that out, okay, and things equilibrate. And I actually overshoot just a little bit. And then I reestablish that gradient, particularly with calcium ions, back to my resting membrane potential, okay? When we talk about polarizing and depolarizing, when we talk about cardiac muscles, at the acetylcholine, the neuromuscular junction, with the acetylcholine receptor, one of the things that happens when I depolarize, I have a massive flood of sodium in, I get a massive efflux of potassium out of the cell, right? So when I use a depolarizing paralytic, I cause every muscle to depolarize. That's why I get hyperkalemia, and why hyperkalemia becomes a problem with the depolarizing agent, because I've universally created a depolarization which drives sodium in, potassium out, and I have a transient period of hyperkalemia. Make sense? So I don't use it in hyperkalemic patients. Okay? That's why all the risk factors for depolarizing agents have to do with potassium. All right? Action potentials in the heart are very unique to the conduction pathway, right? It's the electrical signaling process. So while my ventricular myocytes all do this, when they get triggered, they depolarize. I have very specialized nodal tissue that acts differently because I have a different population of receptors and channels on those cells. They're specialized tissue, right? They're very specialized. It's the oncology of internal medicine, or it's the toxicology of emergency medicine. They're specialized, right? It's the hazmat crew of the fire department. It's a specialized system within that structure that creates a unique task. Okay, they accomplish a unique task. My SA node. Look at the integrity. If I set up and I keep something at a resting membrane potential, I polarize that cell, it stays polarized. It's relatively stable in a polarized state, waiting to be triggered so that when it's triggered, it hits that all or none phenomenon and excites, right? It depolarizes. But if you look at an SA node, I have this very leaky membrane is what it ends up being, with what are called funny sodium channels. But you have this leaky membrane that allows for I set up a gradient, right? I set up a polarized state, but then I essentially allow ions to leak until I reach that threshold potential, and then I get my all or none phenomenon, right? And what does that do? It allows me to generate a spontaneous electrical signal, right? And the SA node does that at about 50 to 100 beats a minute, okay? Right? Because I allow for this spontaneous depolarization to that point of an all or none threshold event, okay? So that becomes a pacemaker. It's just a specialized action potential that results from altering the population of channels and receptors on that cell or that cluster of cells, okay? That makes sense? Technically, every cell has automaticity. It's just the rate that they will reach that threshold event. So my sinus node reaches it faster than my junctional cells that reach it faster than my ventricular myocytes, right? So I have a sinus node, a junctional escape, and a ventricular escape. That's how we have escape beats, right? It's because someone's got to trigger the event. Everybody else is waiting to be triggered, but I need something to trigger the event. Automaticity allows for a spontaneous signal to generate, okay? That cell, or that signal, is subsequently passed from cell to cell, right, through what we call these intercalated discs and the gap junctions in between. So if I flood sodium into this cell, how do I make it trigger the next cell? Okay? If this cell has an event of depolarization, how do I make sure that the subsequent cell next to it also depolarizes? And I do this through these gap junctions. And they allow for passive flow of ions from one cell to the next. Okay? And you can leak in, if I flood sodium in during the depolarization event, some of that sodium leaks into this cell. And that depolarization that occurs brings that negative resting potential up to a threshold point that triggers it to open all its cells. Okay? So I get this kind of wave effect. And if you think of a stadium, it's like the wave going through the stadium. One guy does it, triggers the next guy to do it, triggers the next guy to do it. Okay? Does that make sense? Now, depending on how specialized I am, when I talk about the cardiac conduction system, the His bundle, the common bundle, the bundle branches, Purkinje fibers, they are very effective in transmitting this signal. Much more effective than a ventricular myocyte. And so I get a much easier, much faster propagation of a signal through cell-to-cell depolarization through those cardiac conduction pathways. And that's how they're set up, okay? So I have an SA node that has automaticity, and I have an AV node that has its own specialized membrane to set up for a bit of an AV nodal delay, right? And then I have very specialized conduction fibers in the ventricles to make up the His bundle, left bundle, and Purkinje fibers that really are a result of efficient communication. And so I transmit a signal faster through those electrical pathways than I would from cell to cell to cell to cell in the ventricular myocyte, right? So I propagate a signal here, and that signal is subsequently sent throughout the heart. And if I look at speeds of electrical signaling within the heart, I have an SA node that is a spontaneous generator of an event. I have about a 0.5 millimeter a second depolarization of the atrial muscle, right, which is your brawn of the heart. All it does is contract. It's the muscle cell, right? I have this very slow signaling through my AV node, allowing for an appropriate delay to give ventricular filling, right? And then I have this very rapid bundle of His left and right bundle branches at about 2 meters a second, which is 4 times faster than muscle tissue, right? To the Purkinje fibers, which are 8 times faster than ventricular tissue, right? Followed by depolarization of ventricular muscle, which is as slow as atrial muscle. So what does that give me? It gives me a spontaneous event. My P wave is the excitation and depolarization of my atrium. My AV nodal delay is my delay at the AV node, the rapid conduction of that signal throughout the ventricle so that I get a simultaneous squeeze of the ventricle. If I had a slow conduction, then what would happen is my ventricle would squeeze from top to bottom, right? It would kind of, you'd be milking the heart instead of squeezing the heart. You know, you'd be like, psh, 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 like milking a cow, right? Instead, I take all of that blood and I squeeze it all at once, right? So I get a much more efficient pump, okay? Much more efficient pump. That's the beauty of this rapid specialized conduction tissue, okay? Now if I layer all of these action potentials on top of each other, and I give each one its due in terms of the volume of tissue in the heart contributing to that event, then what I get on my surface EKG is this, PQRST, right? I predominantly see atrial depolarization, and I predominantly see ventricular depolarization because it has the greatest mass. There's not a lot of fibers dedicated to the AV node, to the His bundle, to the bundle branches, to the Purkinje fibers. The vast majority of the mass of the heart is dedicated to the ventricular myocyte, so it makes my biggest signal. Okay? So atrial depolarization, ventricular depolarization, ventricular repolarization. Atrial repolarization is actually hid inside the QRS complex, okay? So that's what it looks like, right? So that's normal conduction. These intervals, the timing that it takes for these events to take place are entirely dependent on potassium, sodium, and calcium and their various receptors on the cell membrane. Does that make sense? We can't talk about this any farther unless you understand that concept. That's why we spend 20 minutes talking about basic cellular signaling, okay? So as a result, I have very predictable intervals, okay? And there's 3 intervals that I care about. My PR interval, right, which tells me how well I'm conducting a signal from the atrium to the ventricle, right? And if it's slow, I get first-degree AV block. I have my QRS interval, which tells me how fast I depolarize my ventricle, right? And then I have my QT interval, which tells me how fast it takes for me to depolarize and repolarize the ventricle, okay? To go through an entire cycle from depolarization to repolarization. and they're very, very predictable, okay? So when I look at this and I measure these out, you don't necessarily need to know the exact time for each one, but you should be able to look onto a 12 lead and the basic grid pattern and say, that's slow, that's fast, right? So I know I'm one big box from the beginning of my P wave to the beginning of my QRS cycle needs to fit within one big box, okay? Make sense? I know that my QRS cycle needs to be at least it needs to happen in the first 3 little boxes, which is 0.120 milliseconds. It needs to be within 3. If it's wider than 3 little boxes, it's a wide complex beat, right? And that just tells me that it's taking longer to depolarize the ventricle, right? And then this QT interval really should be within 2 big boxes. But sometimes with QT, it's easier to say, I'm going to keep it half of the distance between one beat to the next beat, okay? So I say my QT interval needs to be half of the distance of my RR interval. And that's a quick way to eyeball it, to say I know that QT looks long or that QT looks appropriate. That number really needs to be less than 500 milliseconds, and that usually shows up on the 12-lead EKG calculated. But 500 tends to be the cutoff where I start to get a little bit anxious, okay? So don't memorize numbers, make it practical, because it lays out on a grid. Understand what normal is on that grid, right? Now, if I have abnormalities, interval abnormalities, it's going to represent either a conduction disturbance, right, or it's going to represent a membrane channel disorder or channelopathy, okay? And a membrane channel disorder could be inherited in genetic mutation, like in long QT syndrome, where people are genetically born with that. Or it could be because I block the potassium channels with a drug and I give them long QT from cardiotoxicity, right? It's all a reflection of manipulation of a channel. Either I've got a disease channel from a genetic condition, or I've got a disease channel from a toxic effect. Or maybe I've just screwed the level of electrons that are available in the system, and so I've affected it, right? Hyperkalemia, hypokalemia, hyponatremia, hypernatremia, hypocalcemia, hypercalcemia. They all have manifestations on your cardiac action potential. So short PR or long PR interval greater than one big box, right? You can see here to here, that's greater than one big box, first degree AV block, right? My QRS interval, looking at the beginning of my Q to the end of my S, and I'm more than 3 boxes, right? My end of my 3rd box ends right about here, and I still continue out. So I'm a wide QRS, okay? Wide QRS tells me delayed depolarization of the ventricle, okay? Greater than 0.12 or greater than 3 small boxes. I'll talk about that in just a second. So let's talk about bundle branch blocks. And the reason why you have to understand bundle branch blocks is because when we talk about a lot of these pathologic processes, you're going to have a sinus rhythm with a wide QRS, right? And we see that all the time with bundle branch blocks, right? I've got a diseased pathway. The result is I have slow depolarization of one ventricle, and consequently a wide QRS, okay? When I deal with sodium channel disorders, or tricyclics specifically, I get a bizarre wide QRS complex, right? Or hyperkalemia. I end up with a wide complex rhythm when it's really bad, right? So you have to be able to look at a 12 lead and say, that's a bundle branch block, right? And you have to be able to look at a 12 lead and say, that's wide, but that's not a bundle branch block, that's bizarre. Bizarre wide, electrolytes and toxicology, normal bundle branch blocks, I don't worry about it, okay? Make sense? So you really got to be able to look at an EKG and say, I'm 95% confident that's a bundle branch block, okay? So we have to spend some time just briefly reviewing bundle branch blocks. So the bundle the left bundle actually has a posterior fascicle and an anterior fascicle. The right bundle is a single fascicle. So when we divide up blocks, really they're called fascicular blocks. I can have a right bundle branch block, a left anterior fascicular, or a left posterior fascicular. Those are all my unifascicular blocks. Okay? My bifascicular blocks are going to be a left bundle or a right bundle with one of the anterior or posterior fascicles. Does that make sense? Shit. So if I have my AV node here, and I have a common His bundle, left bundle which has an anterior and a posterior fascicle, and a right bundle, each one of these is its own fascicle, right? So, right bundle is a unifascicular block. A right bundle and a posterior fascicular block is a bifascicular block, right? A pure left bundle branch block is a bifascicular block because I take out two, right? That makes sense? The importance is, and the thing that's difficult to distinguish is with right bundle, and the reason we want to pair right bundle and left bundle together is because they give me a wide complex rhythm, right? Because what happens? I get a fast depolarization of this ventricle, but I get slow depolarization of this ventricle, right? So I end up with a wide QRS complex, okay? If I just have a single unifascicular block, right, on the left side, I still get rapid depolarization of this ventricle and this ventricle, so it stays narrow. So unifascicular blocks that are left origin, posterior, anterior, they'll actually result in an axis deviation, not in a wide QRS, because I've altered the pathway of depolarization of that ventricle, okay? So when I talk about right bundle branch block, what does it look like? I have fast depolarization of my left ventricle, right? Because my left bundle is intact. I have slow depolarization of my right ventricle. So slow depolarization of the right, fast depolarization of the left. And what happens is I take what is usually a synchronized depolarization of left and right ventricles, and I split those two apart. I have a fast depolarization and a slow depolarization. So I uncover the two ventricles, and I end up with an RSR prime. Make sense? Everybody got that? So in a right bundle branch block, it's very apparent in these precordial leads. I have an RSR prime. I split those two events. So I take what was synchronized depolarization and I make it asynchronous because one side is slower than the other, right? Together, it widens out that process to make it a wide QRS. Now, back in here, I had this picture of what's called an intrinsicoid deflection. It's the beginning of the QRS cycle, the very beginning, okay? Now, when I look at a bundle branch block, half of my conduction pathway is fast. The slower half shows up on the back end, right? So I have two events. I actually have a rapid fast event followed by a slow event. And you can tell by the slope of that QRS where it's at. So when I'm looking at a bundle branch block, one of the ways I can differentiate disease pathology that is tox or something that's purely ventricular in origin, like VTAC, is I can look at that initial slope. Let's take left bundle branch block, for instance. V1, V2, they always have this really steep R wave, right? Or typically it's an R wave, right? You get this steep R wave, and then it's slow to come up on the other end, right? I'm slow to come up on this end. Now, if I take this and I split it, and I look at my QRS complex from beginning to end, I actually split the event, and I've got a fast side and a slow side, okay? But if I look at a ventricular let's take a pure ventricular beat, like a PVC or a run of VTAC, then what does that look like? Well, I typically have this slow notched down slope followed by a slow up slope. So when I split my event, it's slow on both sides. Does that make sense? So I'm only half slow with my bundle branch blocks, and you can tell that through your intrinsicoid deflection as opposed to slow throughout, which tells me I've got a more pathologic state than just the bundle branch block. So that intrinsicoid deflection can tell you a lot about what you're dealing with. Sit down. Shh. Actually, you're not supposed to tell a pointing dog to sit. It's one of the hard things, because then they go on point and they sit. These people are probably like, what? Okay, left anterior fascicular block. See, here's a fascicular block, but I'm still narrow, right? Because I don't have asynchronous depolarization. They're both getting depolarized fast, but I have an axis deviation, so now instead of being upright in AVF, I'm down in AVF. And remember, I use 1 in AVF to determine axis. If I'm up in both, I'm normal axis. If I'm down in AVF but up in 1, I'm left axis. If I'm up in AVF but down in 1, I'm right axis. Okay? So that's how I tell axis, right? So just a pure left axis deviation with a narrow QRS, a lot of the time is just a left bund or is just a fascicular block. And you can see on this one, I'm a posterior fascicular block. I've got some right axis deviation without infarct or hypertrophy. That's the criteria. Okay? Now with left bundle, I'm wide because I'm depolarizing an entire ventricle slow, right? An entire ventricle is being depolarized in a slow fashion. So I uncover and I widen out that. Now, where do I see that RSR prime in my bundle branch block when it's on the left? I actually see it in 1, and I see it out in my lateral leads. Why is that? Because that's where I'm going to manifest this slow depolarization is going to be out to the left side. Okay? So I get this slow depolarization out to the left. That's where I'm really going to unmask that RSR or that asynchronous depolarization. But where we tend to look is in these precordial leads, right? We see this wide precordial downsloping R wave that's rapid in the front, slow on the back end. Okay? And you see it here. Now the beauty of most EKGs, is that you end up with a dominant sign and then a supporting sign on the EKG. For ST elevation MI, ST elevation is the dominant sign. My supporting sign is that I have that I end up with reciprocal changes, right? Or if I have diffuse ST segment elevation, that makes me think pericarditis, right? If I have PR node depression, that's my supporting part to pericarditis. Diffuse ST elevation with a little PR depression. That's my supporting feature, right? Think of like benign early repolarization, that kind of scooping, subtle ST elevation in my precordial leads. My supporting sign or supporting finding is a little J-point notch in my limb leads or augmented leads, okay? There's always some subtle supporting sign that you can put into to support your obvious diagnostic sign. So we look at these precordial leads for right bundle and left bundle. Big, wide, and down is my left bundle obvious sign. I look over at V6 for my supporting sign, and I can sometimes see rabbit ears, but more importantly, I never have a Q wave in V6 with a left bundle branch block. You don't get a Q wave, okay? So absence of a Q wave with a downsloping big R wave in the precordial leads. When I go over and I look at right bundle branch block, my supporting element is bunny ears, right, in the precordial leads. And then I look over here at V6 and I get a triphasic QRS segment. Okay, and it's not always obvious. You don't see it really well in there. It's not always obvious, but what do I mean by triphasic? My QRS can be QR or S, but it can also be QR. It can be just an R. It can be just a Q, right? So a QRS is a triphasic ST or Q, cycle, right? Here's a QR. Here is just a straight Q, right? So I can have monophasic, biphasic, or triphasic. Right bundle branch block wants to have a triphasic V6. Sometimes this Q is really subtle, okay? So that becomes my supporting variable for right bundle branch block. I'm going to leave this one alone for now, okay? How do I do bundle branch blocks made easy? Right? I do my blinker method, and I look at my J point right here in V1, my J point in V6, okay? And what do I say? I'm up at V1, so I'm turning right, or I'm down in V1, so I'm turning left. That's like the easy way to remember bundle branch blocks, right? But you got to be able to look at this and say, you know what, that does, I got a QRS here in V6 that's triphasic, and I have an absence of a Q wave in V6. This is classic left bundle branch block, right? You got to be able to look at it and say that's classic or that's bizarre, because that becomes your variable for determining a lot of these cardiotoxic effects, okay? So what are some other causes of wide bundle branch or wide complex QRS? Well, I can have a Wolff-Parkinson-White where I'm wide on the front end, right? I got my delta wave that gives me a wide QRS. I can have hyperkalemia, which gives me this kind of bizarre, wide, and eventually sinusoidal-looking QRS in late hyperkalemia. Remember, wide complex bradycardia till proven otherwise is hyperkalemia. And it looks like this. Everybody sees this and they say, oh, shit, looks idioventricular, right? Beware of showing up and calling something idioventricular. Because what's idioventricular? It's this junk box of, I don't know what the hell it is. So I just put all this slow, wide shit into one box and I call it idioventricular, right? So be wary of calling things idioventricular. Think hyperkalemia, okay? Think digitoxicity. Right? There's a number of different things that can do it. What about sodium channel blockers? Sodium channel blockers take my action potential and widen it out, slow it way down. That depolarizing event, look at the slope. Look how long it takes me to depolarize that cell. So what happens is I get a wide QRS. But look at this. It's wide through the whole thing. It's not bundle branch wide. It's diffusely wide. Okay? So now that we understand the action potential, we understand normal intervals and why they're normal and the important elements that participate in cell signaling and how to differentiate a normal appearing classic bundle branch block from another wide complex rhythm, we can start to talk about tricyclic overdose. Okay? I know that was a lot. If we don't cover that first, none of this will make sense. Okay? So, here's a tricyclic overdose. When I look at this, I see several things. Classic tricyclic is a sodium channel blocker, right? So I see sinus tachycardia. I see a wide QRS, and if I measure this out, it's more than 3 boxes. When I look at that, I say, well, shoot, is that a classic left bundle or right bundle branch block pathology picture? Does that look left bundle or right bundle? It doesn't, right? I don't have my classic RSR prime up here, right? I don't have a triphasic V6 for right bundle. It doesn't even really look like left bundle, okay? So it's a bizarre, wide complex that doesn't otherwise fit into a nice category, right? So I say that's a wide complex, bizarre rhythm. So what's my supporting variable for sodium channel cardiotoxicity, right? Wide and bizarre is my first thing. What's my supporting variable or my supporting finding? What clinches that diagnosis? I'll give you a hint. What are you chewing on? I'll give you a hint. It's a lead that we never pay any attention to. We never pay any attention to. AVR. We never pay attention to AVR, right? It's the lost lead. Remember, AVR almost universally is always down. The axis is always down, right? Because where's my positive lead for AVR is out in my right shoulder. Everything moves in this direction, right? So AVR is usually down, predominantly, okay? But if I look at AVR in the setting of sodium channel blockade, I have this prominent R wave in AVR. It's a cardiotoxic R wave of AVR. And that becomes my supportive variable for sodium channel tricyclic overdose, okay? Here's what it looks like. Large R wave in AVR represents cardiac toxicity. You can see how it's growing in this circumstance. Here it's really bad, here it's subtle. You shouldn't really have an R wave there, okay? Can somebody have an R wave in AVR? Sure, they can have an isolated R wave in AVR, but in the right clinical setting, remember, we talk about EKGs here like we're treating an EKG. In the right clinical setting, here's what I'm looking for. If you come in and you have chest pain and shortness of breath, what am I looking for when I get a 12-lead EKG? I'm looking at ST segments and I'm looking for reciprocal changes. If I show up on scene and you got 4 bottles of pills and a love note to your ex-boyfriend, what am I doing an EKG for? I'm looking for interval abnormalities, right? So in the clinical context of potential overdose, I'm going to use a 12-lead and I'm going to look specifically, do I have a wide QRS? And if I do, is it bizarre and do I have a prominent R wave? Sodium channel blockade, okay? Does that make sense? Those are the features of sodium channel blockade or tricyclic. And we treat that in the pre-hospital setting, right? We treat that with bicarb. Why do I give bicarb to someone who is a sodium channel block overdose? Because sodium bicarb has a lot of sodium in a small package, right? So I can give you a ton of sodium to make up for the fact that you've got a sodium channel block. I could also give you normal saline because that has sodium, but I'd have to give you a shitload of normal saline as opposed to giving you a really concentrated volume of sodium ions, okay? Does that make sense? So I'm not giving it for the bicarb, I'm giving it for the sodium, okay? And what happens when I give it? The QRS goes like this. Narrows up, okay? Oh, sorry. So, tricyclics, right? It's a tricyclic overdose, okay? Here's a list of sodium channel blocking drugs. Tricyclic is only one of the sodium channel blocking drugs. We see flecainide in the people take flecainide routinely, right? That's a common drug we give people. Carbamazepine, I think that's Tegretol. It's an anticonvulsant, right? Antihistamines, the beta blockers, particularly propranolol, is a very potent sodium channel blocking drug, okay? Phenothiazines, which are essentially some of the older generation antipsychotics. A lot of the older generation antipsychotics will do that. Here's a drug, cyclobenzaprine, Flexeril, right? Who doesn't have Flexeril, right? I know depressed people never have chronic pain, right? They never have chronic pain syndromes, so they don't always have an ample supply of muscle relaxers and pain medicine around the house, right? Well, here's a very commonly prescribed muscle relaxer that looks molecularly almost identical to one of the classic tricyclics. So what do you think a Flexeril overdose does? It gives you a tricyclic effect, sodium channel blocking overdose, okay? So just because we don't give people tricyclics for depression anymore doesn't mean that there isn't an ample supply of sodium channel blocking drugs in the community. Is it important that you know every possible sodium channel blocking drug? No, it's not, right? I don't have that list memorized. I can tell you about 3 or 4 that are on that list, and I've given this lecture a number of times. I still haven't memorized the list because I don't care. All I care about in a polypharmacy overdose is I'm looking for the effect of a sodium channel blocking drug. And if I see it, I'll treat it. I don't care what drug did it. I'm looking for the effect of it, right? Because the list is long. Okay?
So as far as treatment of that goes, I know we're going to give the bicarb, and we're going to, all right, if we see that change coming, are we going to automatically RSI like we would in a
I would do
no
that.
tricyclic?
I would do that in this. I would RSI somebody if they were sedated and they were otherwise indicated for. I wouldn't RSI them for just a pure because they're a tricyclic overdose. I would RSI them because they were obtunded, sedated, they needed pulmonary protection, their GCS was less than 8, or I thought they were declining, or whatever.
If we see those changes, what I'm going to call
Right.
reciprocal changes
Right.
in AVR, and they're starting to slide on me, now it's time to...
Yep, intubate.
Okay.
Yep. Don't chew on that. So here we go. When I look at this, I think to myself, what is that, right? I'm wide, right? Wide complex rhythm. Hey, knock it off. Wide complex rhythm. Does it fit classically into a left bundle, right bundle? I mean, you could argue that maybe this looks left bundle-ish, right? But I would say it's kind of slow on the front end for a left bundle branch block. In the setting of overdose, I see this. I have a wide complex tachycardia that is, what, 300, 150, 100, about 120, 115 beats per minute. You could look at this and say, maybe that's VTAC, right? Slow VTAC. Well, VTAC doesn't really go 110, 115, 120 beats a minute. VTAC wants to be, slow VTAC's like 160, right? So if I see slow VTAC, then I should be thinking, that's bizarre. That doesn't fit. That's a bizarre wide complex that doesn't classically look to me like a left bundle or right bundle, right? I don't see any RSR prime anywhere in here, right? I don't see it where I typically would see RSR prime in my lateral leads. It doesn't fit. I can't look at this and say with confidence, I'm 95% confident that's a left bundle branch block. You'll never be 100% confident, right? But I can say that's bizarre. Okay? So what do I do when I see bizarre wide? I look at AVR. And look at, sure shit, there's a prominent R wave in AVR. Okay? And that is a tricyclic overdose. Here's another one. I'm a wide complex rhythm, right? Do I fit classically into a left bundle or right bundle? Does this look left bundle, right bundle to you in the precordial leads? Doesn't look left bundle, right bundle to me at all. I can't say that I would put this into a classic left bundle, right bundle type picture. I can't remember what this drug was. But I think it's nortriptyline, which is a tricyclic, right? So bizarre wide, okay? Here's another tricyclic. It's not used in the United States. It's mostly used in Europe, but it's a good example of bizarre wide, right? I look at it, I say, what the hell is that? Is that VTAC? Well, what's the rate of this? Shit. What's the rate of that one? Is, hold on. So what's my rate? Let me find a good one. 300, 150, 100. So I'm still down like 130 wide complex, 30 slow VTAC, right? It doesn't really fit well. Bizarre wide complex doesn't fit a picture nicely. What do I have up here? Prominent R wave in AVR. Okay? And this is a tricyclic also. Yeah?
Is there any kind of an indicator there also?
You know, the times we're notching, you mean notching in the downslope?
Yes.
So the times where notching in the downslope is really beneficial is when you're trying to distinguish SVT with a left bundle branch block from VTAC, okay? Because they'll look fast and wide, really fast like VTAC, and wide like VTAC. And it has to do with that intrinsicoid deflection. We can use that intrinsicoid deflection to help distinguish between the two. Classic VTAC will mimic, if it's from the right ventricle, will mimic left bundle branch block, and you'll see a notching in the downslope in your precordial leads. So notching in the downsloping here will definitely be a hint towards VTAC, but over in here, not so much. okay? So this doesn't really fit VTAC. It doesn't fit a left bundle. It's bizarre, and I have a prominent R wave, okay? Make sense? How about this one? Oh, that's a good one. So wide, what's my rate? 300, 150, 100, 75, 60, so I'm like 60 some, right? 58 is what they said. All right, close enough. So what do I see when I get this one? What could I easily call this? And I wouldn't fault you if you called it that. Yeah, wide complex bradycardia, right? Wide complex bradycardia. But, Mike, you said it, P waves. What do I, by the time I'm this far into hyperkalemia, where does my P wave go? It's gone. That's why people want to call it idioventricular. I got a nice P wave on all these, right? There's a good prominent P wave. So that doesn't go towards hyperkalemia, okay? So what I got is a bizarre wide complex that doesn't fit left bundle, doesn't fit right bundle. Look at AVR. That's a huge R wave in AVR. That's sodium channel toxicity. Do you know what this one is? A potent sodium channel blocker that's on that list. Digoxin's not a sodium channel blocker. It's in a whole thing by itself. Cocaine. Cocaine is a potent sodium channel blocker. So this is a cocaine overdose. You would think it would make you go very fast, but when you have enough cocaine on board that it's saying go fast, but nothing can actually work, then you get rhythms like this, okay? Here's another one. Flecainide was on that list, right? Flecainide, an antiarrhythmic. Well, I had got a wide complex, bizarre wide complex rhythm that doesn't really fit anything, right? It's bizarre. You're starting to see what bizarre looks like, right? Bizarre looks like something that doesn't fit nicely into a box and I can't package it somewhere. That's bizarre. Well, now you've got a whole other compartment for things that look bizarre called your sodium channels, right? And how am I going to put them there? With a prominent R wave in AVR, right? Does that make sense, you guys? Prominent R wave in AVR. I don't know why it's doing that. I hit the laser light and it takes me all the way to the end. It's probably because I'm not in the right mode. That's why. If I take it off the slideshow, it does that, I guess. See, I can be trained. Prominent R wave in AVR, okay? So that's my sodium channel drugs, sodium channel blocking drugs, okay? Let's take a break and then we'll talk about QT prolongation, okay? We're now starting to talk about our QT interval, okay? So the thing you have to understand, just like meth heads and heroin addicts hang out in the same circles, right? They're distinct disease processes, but they hang out in the same circle, okay? So the heroin guy's like, oh, I don't do meth, right? And the meth guy's like, I don't do heroin, right? But you find them in the same house at the same time, right? So it's kind of the same with QT prolongation and wide QRSs in the setting of overdose and toxicity, okay? They both have cardiotoxic effect. They work by different mechanisms. Frequently, they'll be hanging out at the same time, okay? And be cognizant of both of them. The implications are different. What happens to wide QRS in the setting of sodium channel toxicity? Monomorphic tachycardias, okay? Monomorphic VTAC. That's what they will precipitate into. By and large, they'll precipitate into VTAC, okay? We can anticipate that and treat it with sodium bicarb. QT prolongation is a sign of impending torsades, which we typically treat with magnesium, okay? So there's not a lot that I can do to treat QT prolongation. But I can say in the back of my mind, this person has a high risk of torsades, particularly when that QT interval gets over 500, okay? That's why I think I just keep the number 500 milliseconds in my mind, right? So if I have a QT interval that's wide over 500, I'm anticipating torsades, right? So here's an example of QT prolongation. I have an R to R interval and a QT interval, which is half of that R to R interval. That's fine. That's my litmus test for the quick look on QT prolongation, right? If I take this one and I push that T, the end of the T wave out here, well, I've got a prolonged QT, and that's definitely more than half of the RR interval. So that's a wide, long QT, okay? So it's a quick eyeball approach, okay? So what are my causes of long QT? Well, inherited. Some people have inherited long QT syndrome. They're the people who have torsades spontaneously. You show up, resuscitate them, they go to the cath lab, clean coronaries, no other cause for their QT prolongation, right? And their baseline EKG shows a long QT. That's just what they have. That's what they were born with. God made them that way, right? Or, I won't get into evolution versus, they just evolved that way. Electrolyte disorders, right? Hypomag. Where do I see hypomagnesemia? I see, first of all, let me just be very clear about magnesium. Magnesium is an awesome drug because it gives us something to do, right? With very little ill effect. How well does magnesium work? It's not awesome, right? It's kind of like, eh. Yeah, it's why every kid fisherman has a little thing of like salmon eggs, because they're not the best thing, right? You never kill them on salmon eggs, right? But it's easy to come by, and if nothing else is biting, you like throw a salmon egg on there and see if now they'll bite, right? I don't know, you guys fish? If you know what I mean, you know what I mean. If you fished when you were a kid, it's like, I got him. I'll throw a salmon egg on there, right? That's magnesium. I'm not going to kill them with salmon eggs. Right? If I do, I got to figure out where that place is out and take my kid there. But it gives me something to do, right? And it certainly, magnesium plays a role in cardiac conduction. How does it play a role? Quite honestly, I don't think anybody's really can say specifically how it does what it does, right? It's just kind of, we use it to stabilize the membrane. We use it to make it more efficient. There's really no great science to why we have magnesium. I would not be surprised if magnesium went away altogether, okay? It works as a smooth muscle relaxer, okay? So that's why some people use it in asthmatics to help with bronchodilation. It works as a tocolytic to slow down contractions in pregnancy. That's why they'll use it for that. And there's some benefit in the setting of seizures for eclampsia. Again, another one of these electrolytes that is associated with seizures. Okay? So we use it in those settings, but really magnesium is just kind of something to carry. Okay? Hypokalemia, hypocalcemia, and then a number of drugs are antiarrhythmics. A number of drugs can cause long QT. A lot of the antiarrhythmics, a lot of antimicrobials, some of the antidepressants, a lot of the antipsychotics, a lot of the antiemetics, including Zofran, right? Zofran's like safe across the board, universally safe, but I start giving big IV doses of Zofran and I can cause long QT syndrome, okay? We're talking big doses of Zofran, like 15, 20 milligrams IV, okay? So how do I get long QT? This is a series of cardiac myocytes, okay? So as I repolarize down this chain, remember, I go through and I'm depolarizing and repolarizing. Okay, as I'm going back to a depolarized, repolarized state, I can either have QT blocking drugs, which by and large are going to be sodium or a potassium channel blockade, or I can have congenital diseases that alter the ability of that channel to work. Okay? Typically, our QT interval will be reported on an EKG. And again, I'm looking for less than 500. That's what I care about. Okay? When it gets really fast, it's hard to eyeball what's half the RR interval and what does that really matter. So there's a correction called a QTC. Don't worry about calculating the QTC. Most EKGs report the QT as a corrected variable. And it has to do with the relationship of the QT interval to rate. So when you see QTC, it's just the corrected variable for that rate, or the corrected QT for that rate. All right? Here's the drugs that are associated with QT prolongation and torsades, right? Amiodarone, sotalol, which is a beta blocker, procainamide, too many gin and tonics, I guess you can get that one. Antimicrobials, Levaquin. We see Levaquin everywhere, right? I mean, that's kind of like the go-to for anybody with pneumonia or a UTI gets Levaquin. Ciprofloxacin, all of the quinolones. Levaquin, Cipro, moxifloxacin, gadafloxacin. No one uses gadafloxacin anymore, but Levaquin and Cipro are everywhere, right? It's ubiquitous in the community, okay? Erythromycin, clarithromycin. What's the other omycin that we are so frequently running into? Azithromycin, a Z-Pak, right? Everybody gets a Z-Pak, right? A couple of the itraconazole, ketoconazole, these are antifungals. But the joke is someone comes in and you go and you find them and they're like, oh, I just overdosed because life's so difficult, right? And you look and it's like antibiotic. And the joke is, well, you won't get a UTI for the next month. Ha ha, let's go, right? It's purely psych. The truth of the matter is, this could be a cardiotoxic overdose. That person could be at risk for torsades. And how am I going to gauge what their risk is? I'm going to look at the QT interval. Okay? Amitriptyline, again, we'll see the tricyclics in here because they interfere with cardiac conduction and repolarization. So we'll see some of those. Haldol, quietapine, a lot of the antipsychotics, right? So another great example of giving cardiotoxic drugs to an unstable portion of the population, right? They like to overdose. The triptans, methadone, nobody with chronic pain, again, or chronic headaches ever has a psychiatric condition linked to it, right? But here's all kinds of stuff to potentially have a cardiotoxic overdose on, okay? So here's an example of torsades, right? I have polymorphic VTAC, right? Polymorphic VTAC. This was Ty Bruner brought this one in. Polymorphic VTAC. This was a lady that he ran on with an AMR medic, and one of the AMR medics that actually I think it was from our second class, who's a good medic, and the lady was complaining of kind of like palpitations and cold and flu symptoms. Nice lady, really nice lady. It was about 2:30 in the morning, and he decided to write in. Not the most convenient time to write in. He's like, something just wasn't right about this gal. I couldn't put my finger on it. Something just wasn't right about it. And he didn't know what it was. He didn't know what it was that was wrong with her. He didn't know that she was going to have a run of torsades and that they were going to shock her on the way in, but something was just not right. I don't know if there was the palpitation side of things or what. She happened to be on azithromycin. She had just gotten started on azithromycin. She probably had undiagnosed long QT syndrome, got put on to azithromycin, was not an overdose, but her palpitations was actually a run of torsades. And he captured it en route. And if you look at her baseline EKG, I have a QT interval here to here, which is, you could argue, is more than half of the RR interval, particularly when you look at it out here. But when I see my QT corrected, it's 511. So, and I'm not saying that you have to diagnose the torsades before it happens on the little old lady with cold and flu symptoms who's on azithromycin. That's not my point. But here's an example of somebody who just took a bunch of something. I don't know what the medication was. There's a whole plethora. There's a pharmacy of meds in the house, right? She took a bunch of them. And how do I know whether or not there's some sort of cardiac monitoring that needs to take place on this person? Well, I'm going to look at intervals on my 12-lead EKG. So I get a 12-lead, and I look at the QRS. Do I have a wide bizarre QRS? No. Do I have a long QT? Yes, I do have a long QT. This person is high risk for torsades and should be monitored. And then you may decide, you know what, I'm just going to put pads on, and I'm just going to have pads on in case it hits the fan. Because the last thing I want to do is be caught off guard waiting to shock somebody because I wasn't prepared when I could have been prepared because what I needed to make the decision to be prepared was there. And you might show up with your Levaquin overdose and you decide to put pads on them and someone jokes with you in the ER and says, oh, I can't believe you put pads on a Levaquin overdose, right? So she comes in, she gets her workup, and then someone says, hey, so-and-so's got a run of VTAC, and everybody scrambles and panics, and guess who's got pads on them, right? Guess who's ready to be shocked? So the anticipation of what could come down the pipe is what we're doing with the long QT. It's not that I'm going to do anything about it, like in a wide QRS, I'm going to treat with bicarb, but in this circumstance, I'm just telling myself, you know what? Something bad could happen. I've got a setup for it. I see the interval is off. This is how long QT happens. I'm going to be prepared for it. So when it happens, I was expecting it, not I was caught off guard by it. Make sense? Yeah.
I had something very similar a week after ties,
Mm-hmm.
and that's when they said that it was the same thing where she had just had an antibiotic prescribed to her and she was on antidepressants.
Yeah.
And I was told later that that's a certain
Long
combination
QT.
of that causes the torsades.
Yep. And I've given people Levaquin and then got a phone call from the pharmacy and said, hey, you might want to consider changing this. Like, probably should have thought of that before I prescribed this person Levaquin, right? And then we change it.
Frequency, are we seeing this more and more now because of? Or
I think it's happening more and more and we're not capturing it. The truth of the matter is, unless it's a big overdose, it's probably not a big deal. But there's a number of cases every year where we get a sudden cardiac arrest. Someone gets resuscitated, they go to the cath lab, they find no other reason other than a long QT, and they stop long QT meds on them.
we had one the other day after 17s that we shocked the guy once, he came back, and I guess he went to the cath lab and had absolutely nothing.
Had absolutely nothing. But he didn't have long QT, because that's the first thing that came to my mind, and it was the cardiologist's comment was, because that guy wasn't on any meds.
Okay.
He had no meds.
That's what I thought.
Right, he had no meds, and
So
so
I
you
didn't know if
can't
he was
say,
one of those genetic ones or.
and he's going to end up with a defibrillator, and they're going to say he's got idiopathic wide complex tachycardia, which is probably a gene mutation that precipitates arrhythmias. And that's a case of someone who, but if I gave that guy Levaquin, I might have caused his torsades, right? So undiagnosed, you never know. So it could be a small dose, it could be genetic, but in the setting of overdose, when I use an EKG, because I'm going to get a 12 lead on that guy and I'm going to shock him, I'm going to resuscitate him. He already fibrillated or tacked or whatever, right? He already earned the resuscitation. In the setting of overdose, when we traditionally don't use the 12 lead EKG a lot, this is where there's benefit. Okay, does that make sense? Here's an example, long QT, right? Here's the end of my T wave. Here's the beginning of my Q, clearly long QT syndrome. And transition into torsades. And it just happens like that. It doesn't slowly go into it. It just decides now. And it runs, okay? Make sense? That's an excellent example. Long QT. Here's the end of the T wave, beginning of the Q wave. Clearly that QT interval is more than half of my RR interval. You can do that all through there. It's just dying to to run into torsades. Here's another example.
Is MAG a pretty ineffective?
Give MAG, give it, shock them, give MAG, right?
Is it ineffective as a
Oh, like prophylactic mag?
Yeah, like, you know, if you notice long QT and
Eh.
you don't want them going into torsades and
I don't know. I don't, you can draw it up and have it ready, I suppose. I don't think I would give it. I don't think I would give it. Unless, now the hypomagnesiemic group that is at risk for torsades that we classically talk about, and the reason they justify it in ACLS is your malnourished alcoholic, right? Your malnourished alcoholic who has torsades because they have no magnesium, okay? They have no glycogen stores. They have no nothing. They get all their energy from beer, right? And it's a very short-acting energy store. So they're not storing anything away. They utilize it all, right? That's why you look at the bad alcoholics and they got big bellies from their ascites and they've got thin extremities, no muscle mass, right? No muscle mass means no energy stores because all I do is get energy from beer, right? And it's all short-term energy. No long-term storage, no fats, nothing like that, right? So your alcoholic who's in VTAC, I worry about hypomag. Your cancer patient who's in VTAC, you worry about hypomag. And so we give them magnesium. That's your classic hypomag patient, okay? I would give this person mag. Anybody who has an arrhythmia, I'll be honest with you, I get a panel to look at magnesium, calcium. Magnesium I throw in there because you put magnesium in there, right? Sodium, potassium, calcium, magnesium. And I just correct them. Even if they're off by a little bit, I correct them. Even if they're on the low end of normal, I'll give them a little bit. I just kind of like those electrolytes to be at a nice supply, right? Because
ISTAT, will that give you mag?
an ISTAT won't give me mag, but an ISTAT gives me potassium, calcium, and sodium. I don't know if it gives me calcium. It gives me sodium and potassium. I think an ISTAT would be a phenomenal pre-hospital tool. ISTAT lactate, ISTAT cardiac markers, an ISTAT 6, which gives me an H&H plus glucose plus a BUN, a sodium, and a potassium. So it tells me something about renal failure, tells me about electrolytes, tells me about H&H. I think the ISTAT is designed for pre-hospital care, but I think we'll get there.
Going back to the YQRS real quick, what's the dose for, if you see that, for the sodium bicarb?
That's the beauty of toxicology. There's no doses in toxicology, right? It's kind of like cowboy medicine, right? It's like, it's, yeah. I mean, think about organophosphates, right? How do I treat organophosphates? I give it till they dry up, right? And if I get to the upper dosing limit and they still need it, what do? I keep giving them, right? And there's great stories, particularly where you see a lot of organophosphate toxicity in Southeast Asia. There's a number of good case studies because they all use them for agriculture down there, and there's no regulation on what you can use for agricultural chemicals. So there's a lot of organophosphate poisonings and overdoses in Southeast Asia. And there's a phenomenal number of cases where they burn through all the atropine at a facility, so they start using anything else that has anticholinergic properties. Benadryl, Phenergan, any of the, and you just use as many anticholinergic drugs as possible until you get rid of until they dry up, right? Because what is it? Salivation, lacrimation, defecation, urination. It's all the wet stuff. So when they dry up, then that's when I stop. Same thing when I'm treating arrhythmias like this, and I got a bunch of bicarb, what am I going to do? I'm going to give my bicarb because I'm going to get the effect. Well, I don't see it with 1 amp. I'm going to give it 2 amps. I'm confident this is a sodium channel overdose. I'm giving 3 amps, right? And in fact, what I'll do is I'll give a bolus to people, and then I'll set up a drip where I'll take a bag of D5 water, and I'll pull out 100 cc's of it, and I'll take 3 amps of bicarb, and I'll push the bicarb into that. And so I set myself up with a drip that has a lot more sodium than a bag of normal saline, and I'll just drip that in. So for a continuous sodium infusion. Not that you're going to do that because you have boluses and you just treat with boluses, right? Initially, I do that until I get narrowing in my QRS complex. But that's what's cool about toxicology. There's really no rules to toxicology, right? No rules. That's what makes it fun. And part of the reason there's no rules in toxicology is because you can't set up a double-blind trial for overdoses, right? Like, I'm going to take this half of the group and I'm going to sedate you with this drug, and I'm going to take this half of the group and I'm going to induce cardiac arrhythmias. And we're going to give some of you a placebo, and I'm going to give the other new dose of this, right? Here's another example. We'll talk about calcium channel disorders or calcium channel overdose. There's a relationship between insulin and calcium that we'll talk about, and some of the treatment for calcium channel overdose is a high-dose insulin infusion. If you have DKA and I want to give you insulin, I give you 0.1 units per kilo, right? And I drip it in over an hour. So if you're 100 kilos, you get 10 units an hour, okay? If you have a calcium channel overdose, I start at 1 unit per kilo per hour. So you get 100 units of insulin an hour. What happens if you give somebody 100 units of insulin an hour? What does their glucose do? Bottoms out. So you have to hang a bag of D10, and you have to infuse D10 while you're infusing your insulin, and find that sweet spot where they're not hypoglycemic, but they're still getting high doses of insulin. So there's really, there's a lot of grace in your upper limits of dosing for toxicology, which is why it's fun. Here's another example, long QT. Here's the end of my T wave. It happens to be inverted in this circumstance, right? QT, much greater than the RR, half the RR interval. Same thing here. QT, clearly more than half of my RR interval. And what happens? Torsades. And it's a quick transition into torsade. It's not gradual. They're not going to hint at it, right? They're not going to have like a little run of torsade, a little run of torsades. They're going to have torsades, okay? So that's QT prolongation. So we've talked about sodium channel blockade and QRS widening. We've talked about QT prolongation and how to identify those. How about beta blockers and calcium channel blocker overdose? What's it going to manifest like, right? Well, think about these drugs and where do they work? They work at decreasing or delaying the transition of the signal, one, the propagation of the signal, and two, the transmission of the signal through the AV node. So I start to get AV nodal delay, and I start to get slow communication, right? So bradycardia, first degree block, second degree 1 and 2, complete block, right? How do I distinguish the two? Remember, there's a relationship between calcium and insulin. Calcium channel blocker overdose typically presents with hyperglycemia because of reduced insulin release from the pancreas. So what happens is when you take up insulin, there's a relationship of the utilization of calcium or potassium or calcium through that same channel, okay? So when I release it, I require calcium to release it from the pancreas, okay? Interestingly, when I take insulin into a cell, it requires the uptake of a potassium. So when I treat when I get calcium channel blocker overdose, I can do tons and tons and tons and tons of insulin to help mitigate the effect here. But think about in hyperkalemia. What do I treat hyperkalemia with? Bicarb, albuterol, calcium, and in the hospital I use insulin. I give people insulin because the uptake of insulin requires it to shuttle a potassium back into the cell. So I can shift potassium in by using insulin. That's why you see insulin. So it's not that we give D50. We give D50 to prevent hypoglycemia. I give insulin to shift potassium into the cell. Go ahead, Dean.
Flipping that around, if you have a patient that presents with hyperglycemia, then you should be on your guard and check for the beta blockers.
You could do that, but the reality is the vast majority of hyperglycemics are just going to be poorly controlled diabetics, right? But if you get somebody who's obtunded, right? Let's get somebody who's obtunded and they're hyperglycemic or hypoglycemic and they have a slow rhythm, then I might not just blow it off as a diabetic emergency. I might say, there's a possibility toxins really has a place on that differential diagnosis, 5 H's and 5 T's, right? I wouldn't take it off of that possibility, right? Because that's what we're doing. When you work through these cases of critical patients and you're thinking 5 H's and 5 T's, right? I don't want to think about that when they're PEA arrest. I want to think of that before they get to PEA arrest, because I can do a number of things for some of those conditions, right? So I leave toxins on my list of differential diagnoses, right? So some of these things will help work through this, here's my unresponsive, untended patient. What the hell's going on, right? Well, I'm going to get an EKG, I'm going to get a chem stick, I'm going to develop a differential diagnosis, we're going to work through things.
So, quick question.
Yeah.
Slide. So
Yeah.
Not hyperglycemic, glucose is normal, we can consider,
Beta block overdose.
well, glucagon then, right, for these two?
Yeah, but here's the deal. Glucagon is your antidote for beta blocker overdose. How much glucagon do you carry? Milligram, right? Maybe 2 if you're lucky, right? The dose for overdose that we start at, again, we just go till you go, until you get the effect you want, is going to be 0.1 milligram per kilogram. So I need 10 milligrams in a 100 kilo patient, or 7 in a 70 kilo patient. And it's hard to come up with that much glucagon. In fact, I ran a hospital out of glucagon in residency. At least I ran the pharmacy out. There was probably some in scattered code carts throughout the hospital. But the pharmacy, I used up all their glucagon on a beta blocker overdose. And I called some other hospitals and asked if they'd share theirs, and they said no. But, so that just goes to show, you use it until you get the benefit, but it requires a lot. So let's say I got a kid. Here's an example where it'd be beneficial. A toddler, 10-pound kid, right? 20-pound kid starting to crawling around the house. Someone leaves their pills on the floor, right, or on the counter. Kid reaches up, eats a bunch of beta blockers. I got enough glucagon to treat an infant who's eating a bunch of beta blockers, right? Calcium channel blockers, a single pill of calcium channel blocker can kill a kid. It's one of those one pill can kill. There's about 10 of them. Methadone's one of them. But calcium channel blockers are one of those also, where it doesn't take a lot, and I might actually get that benefit. Sorry, pup. That was an accident. So block classification, just a quick review, right? First degree, second degree, third degree. Here's what they look like. First degree, we talked about that. Long PR, wide PR, right? Second degree type 1, I have this gradual increasing and then a dropped beat. So it's less severe than second degree type 2, which has a consistent interval and then dropped beats. This one is less dangerous than this one. And how do I distinguish the two? Well, things that I can anticipate are always less dangerous, right? So this one is what's the word? Telegraphing its intent, right? What was that's not telegraph, that's not the word I'm looking for. But it's like in wrestling, right? When you're younger in wrestling practice, or when you're wrestling some guy, your coach would say, he does this, every time he does this, he's going to do this, right? He's or whatever that word, telegraphing, yeah. So then you're like, all right, well, I know your tell, and so you go back out and you did it, and then you set up your shot early, right? Because I knew that was going to happen, and so I made a move based on an anticipation of an event. So that guy loses, right? Because I figured out his tell. Well, I figured out the tell of Winky Bach, right? So I know what's going to happen, which is opposed to someone who's totally unpredictable, and I don't know what they're going to do because they look normal, and then all of a sudden they're different, right? So second degree type 2 is worse because it's so much closer to complete AV dissociation, like third degree block. And frequently you'll see second degree type 2 drop into third degree block. And I was with, who was I with? I was riding along with Dawson, I think. We had a little old lady up at Pamel. She wasn't a little old lady. We had a gal up at Pamel. She was second degree type 2. She was feeling weak and dizzy. And we had an episode of second degree type 2. And we captured it on a 12 lead, and it was cool, right? And I followed up on her. And shortly after she got to the ER, she was hypotensive, bradycardic, and third degree block, and she ended up getting a pacemaker placed. And she was on the verge of complete heart block. So second degree type 2 is always worse than type 1. What do you see here? When we look at this 12-lead EKG, what do we see? I'm sinus because I got P waves with every QR interval, right? I'm sinus. I'm a little bit long here, so I'm first degree AV block sinus. I'm a little wide in the QRS, so I'm a wide QRS complex. My QT interval is a little outside of 2 big boxes, right? Still probably within half the distance here, but I got a bizarre wide complex sinus rhythm, right? Doesn't fit classically into a left bundle, right bundle. And I got a prominent R wave here. So I got a number of cardiotoxic things going on here. You could argue that there's a fair amount of QT prolongation. You could argue that this QRS widening is due to sodium channel blockade, and I have a first degree AV block. Well, what group or class of drugs do I know is a potent sodium channel blocker as well as a nodal blocking agent? Blocker being the big hint in this one, right? Beta blockers, right? This happens to be a propranolol overdose, which is a non-selective beta blocker frequently used for people with chronic headaches as a preventative medicine, right? So propranolol blocker overdose. Non-selective beta blocker, potent sodium channel blocker. So this could be someone who overdosed on their propranolol, which is in the community like you wouldn't believe, right? So this is someone who's going to actually get admitted to the hospital on a tele bed and monitored before I can clear them for them to be evaluated by psychiatry. And she may be alert and annoying and whiny, and you feel like, hey, this is total BS, right? This is someone who's going to be at risk for arrhythmias. This is cardiotoxicity manifested on the EKG. And you have the tool to identify that early and make sure that they are not okay for a hallway bed, right? Or okay for the orange zone where I happen to work, right? Because what happens when she goes to the orange zone and it is ignored until psych sees her 10 hours later? Hey, so-and-so won't wake up, right? That's not good. That's really, really bad, okay? I would. Yeah, this is sodium channel blocker. I'd treat that. I'd give her bicarb for sure. Absolutely. Because remember, we have a tricyclic protocol, right? But what's tricyclic? Tricyclic is sodium channel blockade. We should rename the protocol sodium channel blockade protocol, right? But then no one would know what the hell we're talking about, right? But if you get somebody on Flexeril who's overdosed and you see wide QRS and you show up and they're sick as a dog and now they're in VTAC and seizing, and I say, why didn't you give sodium? And you say, because it wasn't a tricyclic, I'm not mad at you, I'm just disappointed. It'd be one of those things, right? I'm not mad, I'm just disappointed. Let's talk about digoxin briefly, and then we'll be done, okay? Dig toxicity, there's a joke about in internal medicine about syphilis, that syphilis should be on every differential diagnosis because syphilis can present as anything in its various stages. Acute syphilis looks like one thing, mid-stage syphilis looks like some things, late-stage syphilis can do all kinds of stuff. It can be your psychiatric patient, it can be your heart block patient. Syphilis should be on every differential diagnosis. So, you know, a bunch of dorky med students rotating through the hospital, and the joke's always like, oh, you forgot to put syphilis on the differential diagnosis, right? So, dig is the syphilis of arrhythmias. Dig can present with any arrhythmia, dig toxicity, okay? And we don't see digoxin used a lot anymore, but it has the potential to be very dangerous, okay? And the reason is dig has a very narrow therapeutic window. So if this is the concentration that I need for my effect, which is X, right? I need this much digoxin to get the benefit, right? And that happens to be at this level, okay? So I dose my medication, I take my med, right? Then I come up to this level, and then it peters off. So I have to time my second dose so that the concentration matches that therapeutic effect, right? Make sense? So I'm always over this line, okay? The problem with digoxin is that my toxic level hovers right above my therapeutic level. So I have a narrow therapeutic window, okay? So too much digoxin, and now I'm dig-toxic, okay? So I can either eat a bunch of digoxin and get dig-toxic, or I can alter the rate that I eliminate it, which is through my kidneys. So let's say I give myself renal failure, which is new onset, and I change the slope of all this, right? So now I eliminate it like this, but I keep taking the drug at the same time, and I start doing this. And now I live in the dig-toxic range. So I can have a chronic dig-toxic overdose or an acute dig overdose, okay? So really the most important thing to know is there digoxin around? Because any of these could be digoxin toxicity, which requires a special medication called Digibind, which is the antidote, and it binds up digoxin and makes it ineffective. Just had a case in the ER the other day. It was cool. And it presented as a bizarre arrhythmia that was wide, and it was slow, and it was nothing else. It just was funky, and you couldn't call it anything. And you'd look at it and you'd say, well, that doesn't really fit anything. It's just a weird arrhythmia, and it was dig, which is classic for dig. So you'll get blocks, you'll get slow rhythms, you'll get fast rhythms, you'll get bidirectional VTAC, meaning you'll get VTAC with a positive deflection followed by a negative deflection followed by a positive, so you kind of get the zipper effect, right? Bidirectional VTAC. You can get anything. It'll mimic hyperkalemia. It's bizarre, okay? When it's not toxic, you'll sometimes see the Salvador Dali effect, right? Salvador Dali. You'll see this Salvador Dali, that scooping ST, that dishing out of the ST segment. That's a sign of digoxin. It's called the dig effect. So you'll see that. How does digoxin work? It works by blocking the sodium-potassium pump. So I interfere with establishing that gradient, that depolarized or the polarized state or the polarized resting potential. And I get the secondary benefit by altering the amount of sodium that I have. So I don't have as much sodium out, so I'll push more this way. Well, I'll also get more calcium out, which makes my force of contraction stronger. So you'll see it in heart failure patients to slow the heart down and to make every squeeze more powerful. So you'll see it a lot in heart failure, okay? So here's bigeminy, which is in this circumstance was dig toxicity with bigeminy, okay? Here's another episode of dig toxicity where I have a wide complex, kind of bizarre looking right bundle-ish with a retrograde P wave, but it's irregular with some block. I mean, what the hell is that, right? AFib with the right bundle branch block, but AFib, but then I got a retrograde P wave. It just does weird stuff, okay? Here's bidirectional VTAC, wide complex beat that's down, wide complex beat that's up, bidirectional VTAC. Here's another bidirectional VTAC. See, it looks like a zipper, right? You could almost say, is that electrical alternans in somebody with a huge, big, dilated pericardial effusion, right? But this is bidirectional VTAC from dig toxicity. How about this one? Wide complex bradycardia until proven otherwise, right? This happens to be dig toxicity, unfortunately. What's the lousy thing about dig toxicity? You can get cardiac tetany if you give them calcium. So when it mimics hyperkalemia and you give them calcium, you can get the stone heart effect where they just go and it just stops and it's refractory to everything, which is a theoretical risk. I don't think there's a whole lot of truth to it. But it's always one of the kind of the scare tactics that you learn in medical school to make everybody afraid is be wary of calcium and people with digitoxicity. So I think the important thing to be aware of is anytime I get a weird rhythm, I should consider digitoxicity, okay? Just consider digitoxicity. Syphilis, right? Digitoxicity. Should be on the differential diagnosis of any arrhythmia is digitoxicity, okay? Because we'll give them digibind and it could be potentially life-saving. All right, that's it. Any questions? So those are the big ones. So the moral of the story is you don't have to remember everything that's up here, right? We covered a crap load of material. The whole purpose of this is to introduce you to using the EKG in the setting of overdose as a diagnostic tool. We use the EKG all the time in chest pain as a diagnostic tool. And when I use it in the chest pain patient, I'm looking at ST segments, right? I'm looking for ischemia. I can take this fantastic tool and use it in the overdose setting to identify potential cardiotoxic drugs. There's a lot of cardiotoxic drugs in the community. I'm not pretending to know every single one of them. But I do know there's a couple things to look for that are related to interval abnormalities. Some of them I can treat with sodium channel blockade. Some of them I can just be prepared for the worst with long QT. Some of them I might identify and start treating if it's an beta blocker overdose, right? But I'm going to use my EKG as a diagnostic tool when I'm dealing with overdoses, so we have more in the toolbox than Narcan and intubate if they're really bad, right? Because I think we get into the setting of overdose and it's like, shit, give them Narcan, right? We give overdose patients Narcan. If it doesn't get better, then well, it's something else, right? Well, there are other things that can be treated in the pre-hospital setting, but you've got to have a 12 lead to navigate the overdose patient, okay? Yeah, Ed.
To get
Bicarb? No. You know, it's in the protocol. And actually, the protocol is really generous, right? If you notice and you read the protocol, it's greater than 100 milliseconds, which technically is still not a wide complex rhythm, right? But so if I got, and that's for classic tricyclic overdose, so if you got like bottle of imipramine, right, which really, I think they only prescribe imipramine to teenage kids who wet the bed, right? But, so it's out there, it's just not typically what you'd remember it, but amitriptyline, imipramine, all those drugs, if I look at them like, clear cut, calcium channel blocker, overdose, I'm not even going to wait for the QRS to get wide, I'm just going to start giving them bicarb, right? If you look at the protocol, it's very generous on when you can start giving bicarb. Now, if I got a polypharmacy overdose, I don't know what they took. They just have a plate full of pills and they took a handful of them, and I see widening of the QRS, then I'm going to be sure to look at that AVR, have proof that I have a cardiotoxic effect, sodium channel cardiotoxicity with an AVR in the setting of a wide QRS, and then I'll treat it. And you don't have to call in for that. That's sodium channel blockade overdose. But save your EKG so that you can justify it. And if you get a case like that, send it to me because toxicology is one of my favorite things. Okay? All right. Any other questions? Thanks, guys. Thanks for coming.